How's it going, guys? Past level question, Gastro, steps 1 and 2, 82-year-old man, 12-hour history, severe low abdo cramping, moderate distension. He's got evidence of prior appendectomy, the McBurney point scar here. And then we've got an abdo x-ray. I'll talk about his new question. Should I say adhesions? Wrong fucking answer. So, aka fibrous adhesions. If a patient's had prior major surgery on the abdomen, i.e., laparotomy, female abdominal hysterectomy, you can get inflammation within the peritoneal cavity that leads to fibrin deposition, which leads to fibrous strand formation called adhesions, and the small bowel years later will find its way to get caught within those fibrous adhesions, leading to an acute SBO, small bowel obstruction. So, for example, they could say this 82-year-old dude, he had a gunshot wound to the abdomen 20 years ago and had a laparotomy performed, and now has basically the same presentation. And instead of showing you this x-ray, they'll tell you in the stem, they'll say, abdominal x-ray shows dilated loops of small bowel with air fluid levels. That's a very buzzy descriptor. That means small bowel obstruction. It's not specific for any one diagnosis, and that would be adhesions. And then for TCK, they want a triad of management for SBO. Number 1, NPO, which means nothing by mouth or bowel arrest. Number 2, 0.9% normal saline. Number 3, NG tube. They can write it as nasogastric decompression. Adhesions, wrong fucking answer. Choice B, cancer of the cecum, wrong fucking answer. So I've seen this as a favorite NBME wrong answer, okay, on a few of the questions where what they'll do is they'll give you some old dude who's got GI bleeding. You'll easily be able to eliminate 3 of the answers, and you're left with cancer of the cecum and descending colon cancer, and the answer is descending colon cancer. The student asks, why couldn't it be cancer of the cecum? It's not outrageous. It's just not as likely as just large bowel cancer. The cecum is what separates the small bowel from the large bowel. If they were to push you onto the diagnosis, for example, a patient has Crohn's, which classically affects the terminal ileum, but although mouth to anus, and the patient has B symptoms, fever, night sweats, weight loss, so you can eliminate the other answers, sure, we could have cancer of the cecum as a theoretical answer, but I've just never seen it as a correct answer. Only a wrong fucking answer. Choice B, wrong fucking answer. Choice C, ileus, wrong fucking answer. So, aka paralytic ileus. This just means transient diminished peristalsis of the small bowel in the setting of a stressor, classically surgery. Can be things like electrolyte disturbances or sepsis. So they can tell you, for instance, patient had GI surgery, and then for the 4 or 5 days post-op, hasn't passed stool or flatus. That's called obstipation, if you haven't passed flatus in addition to stool. And that could just be a paralytic ileus. Wrong fucking answer. Choice D, Intussusception, wrong fucking answer. 99% under the age of 2. Okay, is it possible in elderly, e.g. in the setting of cancer? Yes, but under the age of 2. They're going to give you the classic vignette of squatting, intermittent squatting, crying, lifting legs toward the chest. There could be blood in the stool, and there's classically a right lower quadrant sausage-shaped mass, which they don't have to mention, but it's very buzzy. And the hardest, and you're going to do a ultrasound followed by an enema, the latter being therapeutic and diagnostic. Okay, they'll often have like air enema, air contrast enema, water soluble. It doesn't matter. Just any type of enema is the treatment, but they can be very tricky. And the high yield point I can tell you is that you need to know congenital midgut volvulus in pediatrics, and intussusception can present exactly the same way, and that blindsides students. The difference is that there's no mass in midgut volvulus, but there's a mass in intussusception. Okay, if they have congenital midgut volvulus, they can tell you dilated loops of small bowel with air fluid levels. They do that on one of the 2CK PEDS forms. Okay, they say there's no mass. They say dilated loops of small bowel with air fluid levels on abdominal x-ray, and the answer is volvulus. Intussusception's wrong. Okay, wrong fucking answer. Choice C, sigmoid volvulus, correct answer. I said it's pass level because our x-ray is showing you the coffee bean sign here. So this is classically going to be a patient over the age of 70. Old patients with large floppy sigmoid colon, where you get this coffee bean sign on x-ray. If you don't know what I'm talking about, you follow my cursor here. Okay, so this large coffee bean that we've got. You're like, oh yeah, I kind of see a coffee bean sign. I have this in my GI PDF. Okay, I've linked it below. I have it in my other PDF, surgery, internal medicine. It's a diagnosis you got to know, and based on the demographic as well. So even if you weren't sure what's going on, I mean, I'd say that the challenge could, in theory, have been adhesions versus volvulus. The patient does have prior surgery, but you're not going to have this X-ray. As I told you, they'll write dilated leaves, small bowel air fluid levels. This is coffee bean sign, sigmoid volvulus. Okay, maybe medium difficulty. All right, but it's very buzzy, and some of you knew this right away. And I can tell you, I've seen as a management step, as a correct answer in NBME, they want sigmoidoscopy guided insertion of rectal tube. That's an answer. I just quoted that. It's on the NBME exam. They'll give you the same fucking X-ray here. Say what's the next? They'll say like fluids are given and nothing by mouth, etc. And then they'll say sigmoidoscopy guided insertion of rectal tube. Sigmoid volvulus. Correct answer. You know the deal in 2 make more content on your subscription. Appreciate your time. That's a